First, we are going to look at pathogenesis. Several pathogenic factors promote OA. These include altered cartilage extracellular matrix, genetic, aging, and abnormal loading of the joint, obesity, joint injury. These changes cause alterations in all structural components in the joint. Chondrocyte activation producing matrix metalloproteinases and cytokines which cause cartilage breakdown. Synovial inflammation. Abnormal remodeling of bone due to synovial inflammation and cytokines from the chondrocyte. Altered muscle and tendon function with associated proprioceptive and vibratory deficits. These alterations clinical features. Activity-related joint pain, gelling and instability with loss of function. Osteoarthritis commonly affects the knee joint and hip joint. Deformity, asymmetrical involvement. Investigations. Blood reports. No elevation of inflammatory markers. Non-inflammatory joint fluid, presence of joint crystals identified. Radiology. There is poor correlation between clinical features and joint damage. Narrowing of joint spaces, subchondral bony sclerosis and marginal osteophyte. Look at these two X-rays. The white shining area name is sclerosis, that occurs due to touching femur and tibia each other. There also loss of joint spaces. Degenerative changes indicate osteophyte which are abnormal bony formation. Subjective examination. Pain low intensity, aching type, referred down from an affected joint, sharp stabbing pain with loose bodies, throbbing in acute inflammation which is worst at night, pain on weight bearing, during and after exercises, night pain. Stiffness present after rest. Crepitus. Characteristic sound on movement due to grating of cartilage flakes and exposed bony ends. Loss of functionality. Due to observational assessment. Muscle wasting, probably opposite to contractures. Joint enlargement due to edema and muscle wasting. Deformity, specific to joints. Gait deviations, look at below pictures. Next, move on to palpation. Muscle spasm. Trigger points. Temperature. Next, move on to other part of the objective assessment. Active and passive range of motion of knee, hip and ankle. Muscle power around the muscles hip, knee, and ankle. Gait. Balance. Proprioception. Functional assessment. What are the physiotherapy goals? Number 1. Patient education. Relieve pain and muscle spasm. Maintain muscle power. Improve range of motion. Improve coordination and balance. Prevent deformity. Weight reduction. Advise patients. Next, move on to treatment. First, reduce pain. Ice therapy for acute stage. In the chronic stage, superficial heat like IR and deep heat like shortwave diathermy. Accessory movement grade 1 and 2 for patella, tibia and femur. Reduce muscle spasm and trigger point. Dry needling, cupping, and kneading. Improve range of motion. Joint mobilization exercises, accessory movement grade 3 and 4 for patella. Prevent deformity. Strengthen the weak muscle and stretching the tight muscles. Isometric contractions in inner range, hold for 5 to 10 seconds. Ask the patient to count 8 to 10 repetitions, 1 to 2 sets, once a day. Isotonic exercises 10 lifts, rest, 2 to 3 sets. First with holding, then with a weight without holding, once a day. Weight should be less than 75% of 10 rm. Stretching exercises. Hold for 15 seconds, 3 sets, once a day. Reduction of body weight. HIIT